all, as doctors, dealt with patients in some level of critical care status, some of them with infections, including some community-acquired pneumonias. So the question really is whether COVID-19 is similar to what we have seen before, or is something very unique, and arguably most to say it's something very unique. With that in mind, there's no cure, there's no drug, there's nothing that we can inject, swallow, or administer that will wipe it away. There's nothing like an antibacterial that can deal with some of the other bacterial pneumonias or even tuberculosis that we've seen. There's no silver bullet. So we're therefore left with our critical care tools, supportive therapy, and pharmacological interventions. So today is an opportunity to share our experience. And once again, thanks everybody for joining us. We have a very distinguished panel here with us today. I'm going to use the opportunity to introduce one of our eminent colleagues, Dr. Yemi Johnson, who is joining us from Nigeria. Many of you recognize him. He is a doctor of significant repute. As an introduction, Dr. Johnson studied medicine at the University of Lagos, and then subsequently traveled to the United States, where he did a public health degree at Yale University School of Medicine. Subsequently went to Columbia, where he did his internal medicine residency and also a cardiology fellowship. This was followed by an interventional cardiology fellowship at Loma Linda, which I believe is in California. He also has tremendous experience in practice, including on the administrative side, clinical side, and research. The CV is really lengthy and laudable, and I'll make it brief, not to deny him his credit, but in the interest of time. But he has had distinguished practices on both sides in the US and then subsequently in Nigeria, totaling over 25 years. He's currently practicing at First Cardiology in Lagos as an interventional cardiologist, where he also manages intensive care patients. He brings that breadth and depth of experience to today's discussion. So Dr. Johnson, welcome. I'll allow Dr. Getty, if you can hear her, to introduce the other two speakers, but I'll introduce Dr. Getty first. Many of you might already know Getty Anyanwoke, who is an infectious disease doctor. She's a fellow of the Infectious Disease Society of America, has demonstrated an authority in infectious disease, particularly pertaining to COVID-19, and has led the ANPA membership and the Nigerian community in general in multiple discussions, both on the teaching end and in other dialogue on COVID-19 since the onset of the pandemic. She wears many hats. Is also the chair of the ANPA COVID-19 Task Force, the ANPA Infectious Disease Committee, the ANPA Louisiana chapter, and is medical director of the multi-specialty care of Baton Rouge and infectious disease specialist also of Baton Rouge. So she clearly has a lot to bring to the table and has treated tons of COVID-19 patients. So Getty, if you can go ahead and introduce the other two speakers. We have you on speakerphone.
Thank you so much, Aham. And I am truly sorry about the technical kerfuffle. I hope it's still a pleasant experience for you all. Thank you. Welcome to this great conference and great partnership with our Nigerian colleagues. It is my pleasure to introduce Dr. Ngozika Ojioke. She is a FCCP, a fellow of the of that college. She's co-founder of Covenant Pulmonary Critical Care Incorporated. She's past pulmonary director, Critical Recovery Hospitals, co-founder of the CMG group. She's a member of ANPA Educational Advisory Board, and she serves as faculty in Atlanta area graduate medical education, internal medicine residency program. Ladies and gentlemen, I give you Dr. Ngozika Ojioke. Dr. Ngozi, thank you and welcome.
Okay, Getty, I see you've joined us now. Are you on mute?
I can't I was able to join on that one, but I can't have the 2 volumes because it's going to
echo.
Yeah.
Okay, I can hang up here and then let you go.
No, don't hang up. Don't hang up.
All right.
Okay, so you can go ahead and introduce Dr. Makenjola, then Professor Okunseri will have to give us a few words. Thank you.
Okay, actually, you can introduce Makenjola. I don't have his.
Okay.
Yeah.
So our next panelist is Dr. Akinloye Julius Makenjola. He's also FCCP. He's a founding member and co-principal of CMG Healthcare Limited. He's medical, laboratory, pulmonary, and critical care program director of some local acute care hospitals, intensive care units, long-term acute care hospitals, and nursing home programs in the Atlanta area. Dr. Makenjola, you're welcome, sir.
Thank you.
Okay, so we'll take the opportunity to introduce the current president of ANPA, Dr. Chris Okunseri, who's here with us today. He will make some opening remarks, and then Dr. Makenjola will go ahead and give a brief talk, and then we'll have an open discussion after that. Dr. Okunseri.
Thank you, Dr. Aham, and a big thank you and welcome to everyone on this conference or on this webinar at this point. On behalf of the Association of Nigerian Physicians in the Americas, I welcome you all, but I want to first of all apologize for the late start. As you are all very much aware, when technology works, it works beautifully well. When it doesn't work, then there's always a problem. This is one of a situation where we're having some hitch with our technology. However, I feel strongly that we will take care of it hopefully before the end of this process. However, I think a big opportunity for us all, Association of Nigerian Physicians in the Americas and our counterparts back in Nigeria, working together to achieve this learning opportunity for all of us. But I also want to take this opportunity to give a big thank you to the committees within ANPA, Infectious Disease Committee chaired by Dr. Getty Ayanwoke, and the COVID Task Force, and also the membership committee, the advocacy committee. You can see this is a clear example of where people or where committees work together. We can move things forward. We can achieve ANPA's vision of a healthier Nigeria in a healthier world. So I applaud everyone, and I want to take this opportunity to say, please, let's not allow this to end. Let's continue to work together, because at the end of the day, we want to improve the health of our population in Nigeria. And on behalf of the organization, without taking too much of our time, I want to say thank you and sorry for the late start. So thank you very much, everybody. And I look forward to an exciting opportunity to learn more from you guys as you guys learn from each other as well. Thank you.
Okay, thank you, Dr. Okunseri. So we'll call on Dr. Makenjola to make a brief opening lecture, and then we'll open the floor. During his lecture, we'll encourage everybody to use the chat function for questions as they come up. In addition to our panelists, we have multiple other experts in the room who've taken care of COVID-19 themselves. And so the chat is going to be dynamic and engaging. After Dr. Makenjola's lecture, then we would pull questions based on the moderator's discretion to be discussed in the general forum. And we would engage our panelists whose experiences we're counting on to lead the discussion. So Dr. Makenjola, you can go ahead and unmute your mic, share your screen, and we can get started.
Are you going to project the slides?
I don't have them. Let's see. Tayana, do you have his slides?
I do not. Were they sent to Letitia?
Not sure. Okay, give me a few minutes.
Dr. Yanauku should have the slides.
Okay. I know it was emailed.
Or Tanya, can you give him, the presenter, host responsibility so that he can share his slides directly?
Yes, he could share his slides if he has them, but I do not have his slides. But if you send them to me, I will present them. I will post them as well.
Yeah, I'll send them to you. Gertie, can you text them to her? Because I don't know how to share my screen with you.
Okay, let me see what I can do here.
If you look carefully, you have your screen. If you look carefully on
Okay.
share screen, just click on that if you have the privilege, and you can share your screen right away.
Okay. Dr. Makanjuola, sorry for the hiccup. In the meantime, we can get. We're going to pull you his slides and share them. In the meantime, we can get started with this discussion while waiting for that to happen. Interest of time.
Sorry, can I? Yeah, if I just jump in here, because at the end of the slides with Dr. Makanjuola, the idea was I was going to just look at some of the data that's published for some of the medications we're using and some of the things that we do. So if you want me to, I can start with that. Definitely. Will that work? Okay, so let me start with some of the data that's published data, randomized controlled trials, looking at the medications that are being used. And I'm going to specifically just talk about the critical care arena, if that's okay.
Certainly.
All right, and then Dr. Makanjuola, once you're ready, just let me know, I'll stop, and then we can go ahead and continue with the slide presentation.
Okay.
Okay. All right, so the first study I'm going to look at, because that was a randomized control study, and it was looking at steroids in the setting of COVID-19. And so in the recovery trial, basically what was found was with patients who were not on oxygen, if you gave them steroids, it tended towards harm. And so the recommendation is that if they are on steroids, you've got a positive result, or they're hypoxic when they come in. The steroid of choice was dexamethasone. It was given at 6 milligrams per kilo, 6 milligrams daily, whether it was intravenous or oral. And recommendation is to give it for 10 days. When patients have BMIs that are greater than 35 and heading towards the super BMIs, IV twice a day, and do that for the 10-day period. Now, in that setting, if you do give them steroids in the setting of not requiring supplemental oxygen therapy, there is a tendency towards harm, and the p-value was pretty significant in that particular trial. It's the largest trial that we have with respect to steroids in the setting of COVID and COVID ARDS and COVID hypoxia. Now, some of the things that were also noticed was that lung compliance in COVID ARDS, and ARDS is acute respiratory distress syndrome, lung compliance is a lot better than what you have in regular ARDS. So there was this information. They now started looking at whether it had to do with the kind of inflammatory cytokines that were released in the setting of COVID. So there is recent data that supports interleukin-6 blockage. When we first saw COVID, we're using tocilizumab, which is an anti-interleukin-6. Dr. Makanjuola, are you ready for the slides?
The slide is up.
Sorry. Yeah, I see a slide. I just wanted to be sure he was ready to start the presentation, then I can hold off.
There we go. Sorry, I was trying to unmute myself. So I'm ready to start whenever.
Okay.
Are you ready with
you go ahead.
Slides? Yeah.
Yeah.
Okay. So again, sorry for the hiccups we've had today. I'll be relying on whoever is controlling the slides to move to the next slides. I've been introduced, and we can go to the next screen. So my hope is that at the end of this lecture that we're going to understand some of the identification and management of basic manifestations of critical illness from COVID, that we all will get some critical care pearls that we can actually take into our practice. At the first time I did a lecture like this, I did mention that safety is still the most important aspect of management, and I guess that is the same thing at this point. I tried to make this lecture as interactive as possible. It's going to take somewhere from 20 to 25 minutes, but I'll try and speed it up as fast as I can, and I'll be speaking pretty fast as a result of that. Next slide. So I call the lecture COVID Warriors. And really, when you think about it, I'm talking about you, my colleagues on the other side of the Atlantic over there, who perhaps don't have the personal protective equipment, the healthcare infrastructure that we have, but still have to face this COVID pandemic. So you are the warriors, and I appreciate all you do, and thank you very much. So next slide. So I will try and make this interactive. I will talk about a patient that is actually a real patient that we took care of over here, are still taking care of, and then just give her a number. So this is patient number 00136. 0331 by the name of Hadiza Chukwu Afolabi. Now, I checked the WHO website, I believe yesterday, and in Nigeria, 136,030 people had been infected officially, of which there were 1,632 deaths. This is in a country of about 200 million people. So when I compare it with the United States, it's about 2/3 the size of the United States. We have close on 500,000 that have died here, and it just is surprising that we have just 1,632. If that is true in Nigeria, then thank God for that. But again, it's a scary sight. She's a 78-year-old female. She returned from a trip to the US. Her vital signs at presentation 101.9 degrees Fahrenheit. I think that's about 39 degrees Celsius. She was tachycardic, 131 on the pulse, breathing fast 40 times per minute. She was hypotensive with a blood pressure of 74/22, and her O2 sats were 72% on room air, which is what we find in a lot of patients. They've been having dyspnea and exertion, shortness of breath, just didn't feel well. And it was because when we do test them, they test positive for COVID-19, in this case on the PCR test. Next slide. This is her x-ray when she came into the hospital. I will try and translate it into perhaps a rural area where you have no radiographs to look at in your patient. So this patient might have some dullness to percussion, perhaps in the left lower chest wall posteriorly. She might have some crackles more prominent on that side, but probably will have crackles mostly in both sides of her lungs in the bases. Next slide. This is another patient with COVID-19, and the point being that there is really not one particular image. You find infiltrates usually in both lung fields, but the degree of the infiltrates do not always correlate with the degree of infection or clinical symptoms. So this patient has a lot of infiltrates and a very significant process going on in the bases of her lungs. But if you compare with the next slide, please. This patient perhaps has less consolidation, but a more diffuse infiltrate, and you can tell that she's intubated in this patient. So you can't really tell by the x-ray picture. You will probably hear crackles in this patient, or when you listen to her, probably no dullness with percussion. You might even hear some wheezing, but there's no classical sign for COVID infection. Next slide. A similar kind of patient intubated on the mechanical ventilator. There's more of a process going on in the left lower lobe region, perhaps more of an effusion there. So dullness to percussion, reduced air entry in the left lower lobe area. Next slide. This is an X-ray picture, a CT scan, sorry, bilateral infiltrate. She has pleural effusion. So if this patient is sitting upright, you will expect that the effusions will layer to the bottom, and you might again have some dullness in percussion and reduced air entry in the bases. Next slide. This patient in particular has a lot of consolidation going on. So you might hear the classical egophony that we hear on auscultation and changes in vocal tone when you do listen to it. Next slide. So on my way to give this lecture in Nigeria, I decided that I would go ahead and buy this piece of equipment. For some reason, it's not, it's not showing well, but it cost about $3,900, and the machine itself is called an iStat. It's about the size of a Coca-Cola bottle, maybe a little bit bigger than a Coca-Cola bottle. But I will make a point with these purchases I made a little bit down the road. So this costs about $4,000. It's a pretty sum for most people, any part of the world, but for an upper class, maybe upper middle class, and certainly for governments, I think that this is something that is affordable. Next slide. As a result of the ISTAT machine I bought, I was able to get an arterial blood gas. This patient had a pH of 7.09, definitely acidotic. It was primarily a metabolic process. The bicarbonate was 13. PCO2 was 46, so not much of a respiratory component to this acidosis. PO2 was 85 on 100%. If you calculate the PaO2 FiO2 ratio, this is a lady that's less than 150, certainly with severe respiratory distress syndrome. Next slide. So I asked a colleague of mine over there in UCH, an anesthesiologist, who was kind enough to give me some questions. He asked, do we have an algorithm for escalating ICU care for patients with COVID persistent hypoxemia, despite simple face mask oxygenation? And the answer is yes, there are multiple algorithms. Next slide. I picked this particular algorithm from the Chest magazine. So your patient comes in, step one, no respiratory distress, oxygenation is pretty decent, 92 to 94 should be better, but this is declining. So there's worsening hypoxemia. You have her on a nasal cannula, 4 to 6 liters flow per minute. She needs more oxygen. You put her on 100% non-rebreather mask. You just had a flow of about 15 liters per minute. But despite this, she's still short of breath. You go to step 2. She's now in a mild to moderate respiratory distress, PaO2, FiO2 of 150 to 300. You have modalities that include awake proning, which is something that can be done anywhere, usually combined with either high flow nasal cannula or non-invasive ventilation. And finally, if the PF ratio falls below 150 or you're in severe acute respiratory distress, you have no choice but to proceed to intubation most of the time. That is if the patient does not carry a do not resuscitate, as a lot of patients carry over here. They do have a right to decide to refuse treatment. Next slide. So question 2, in my experience, in our experience, does prone positioning make any significant difference? I will tell you, I was not much of a believer in prone positioning until COVID came. The studies had shown that it does improve oxygenation, but really hadn't shown a mortality benefit, and I always didn't pay more attention. But the answer is yes, with COVID, I am a firm believer in proning. Next slide. What proning does essentially, if you think of somebody laying on the back with a lot of dependent infiltrates in the bases of his lungs, air cannot get into those alveoli, so the air preferentially goes into the free space, causes overdistension, causes barotrauma and other types of lung injury. So proning patients improves VQ and shunt by redistributing the infiltrates. There is less compression of the dorsal regional segments of the lungs, also improving perfusion and VQ matching, and it definitely may facilitate drainage of respiratory secretions. In a nutshell, it makes ventilation more homogeneous and improves the oxygenation and ventilation of the patient. Next slide. It can be used alone. When the PF ratio is less than 150, you really should be thinking intubation, but can be used cautiously in some patients. As now, one thing we have learned is that early intubation does not necessarily translate to increased survival. In fact, although it's institution-based, some people actually tend to keep intubation for the very last result. And it's best in patients that have diffuse infiltrates on their chest X-ray. Next slide. When you prone somebody, don't forget, you need to protect the precious points. I mean, studies have shown that in just 6 minutes, skin that is under pressure can begin to necrose. So use pillows under pressure points, the shoulders, the knees, the sacral prominences. Avoiding patients that have a fresh tracheostomy, for example, chest tubes, anything that can dislodge. It really makes just common sense. Unstable spine fractures, you don't want to put them upside down. And then in the first trimester of pregnancy, it's said that you probably should avoid proning. Next slide. So our patient is now moving to, despite our proning and everything, they need more help. And so we need to move to one of the other modalities, high flow or non-invasive ventilation. Next slide. I I picked up this instrument also on my trip to come give this lecture. It cost about $1,300, $1,400. Again, not something that everybody can put their hands in their pocket and buy, but certainly something that institutions and philanthropists should be able to provide. Next slide. That machine is a high-flow nasal cannula machine. It delivers oxygen at a flow rate of about 40 to 80 liters per minute, as against the 15 liters or less with a non-rebreather. It has a soft interface. Those nasal prongs go in your nose, and therefore you still have an element of a certain degree of independence, and it's easier tolerated. Next slide. So this is high flow oxygen. It's heated, it's humidified in that machine and delivered 40 to 80 liters per minute. The heating and the humidification, I recently had a procedure and put in oxygen at 2 liters flow and really began to feel what it's like to have oxygen in your nostrils. By the time it's going around 8, 9, 10 liters, it's drying you out. So this has a lot of heating and humidification that reduces desiccation of the nasopharyngeal mucosa, makes it easy to tolerate. Next slide. The soft, loosely fitting nasal interface, as against the BiPAP, the non-invasive ventilation, which we'll talk about next, makes it easier. And there's something for a patient to still have their independence. They can eat while they're on this machine, they can watch TV, and they still are able to mobilize secretions as a lot of the heat and humidification. Next slide. So another thing is that just the physiology, you can imagine the high flow nasal oxygen hitting your upper airways. It flushes the airway out, reduces dead space, and you can imagine that during exhalation and at end exhalation, the first bolus of air during inspiration is actually this high flow oxygen, as against pulling in dead space. Now, as you know, patients that are dyspneic are air hungry, they're struggling, they're generating flow rates that may exceed 60 liters, 70 liters per minute. So the extra flow that you get when you set your high flow at 50, at 60 liters per minute, just makes it more comfortable for the patient, reduces walk of breathing, and makes it easier for them to tolerate. Next slide. Excuse me. So as I mentioned, it washes out dead space, it improves ventilation also, and then it generates a pressure. The expiratory impedance creates a type of positive end expiratory pressure that has been measured at about 1 centimeter of water per 10 liter flow. So when you get flows of 50 liters, 60 liters, you're actually generating PEEPs of about 5, 6, 7 that improves alveolar recruitment and oxygenation. Next slide. So this is our patient again. As a result of our machine, we're able to get some more tests. 6 hours into this presentation, her temperature is 99.2 Fahrenheit. Pulse is still 130. She's still hypotensive, and she's still hypoxemic. Next slide. I also picked up this machine. It's a non-invasive ventilator. Cost about $1,000. And next slide. Next slide. This is the interface between the machine and the patient. It's tight fitting. You don't want to use it on a patient that may vomit or throw up. Next slide. So high flow nasal cannula improves oxygenation by flow. Next slide. With non-invasive ventilation, it's a pressure situation. The generated extra pressure improves the oxygenation, improves alveolar recruitment. Next slide. It initially came from cardiac literature. It's best in acute pulmonary edema and works well in COPD. You can think of a balloon. You set a high pressure, you set a low pressure. It blows it up to a high pressure and then it reduces to a low pressure. So you improve ventilation. So you use it in patients who are retaining CO2. Next slide. So this patient was placed on BiPAP, and after a few more hours, you can see that her PCO2 has been blown from 46 to 21. The pH as a result is up to 7.21. Her PO2 is up to 94, but she still has a pretty significant metabolic process with a BiCAP of 8. Next slide. We still, as a result of this same machine, we're able to get some more lab data. Next slide. So this is a way we write labs here in the United States. The white cell count, 9,600, hemoglobin 15.4, hematocrit below that, the platelet count, 226. This patient's sodium is 166. They're hemoconcentrated, they're dry, potassium 5.6. The BUN is 76, the creatinine is 2.0. So the kidney injury is also affecting the acidosis or contributing to the acidosis. She has a BiCAP of 17, a glucose of 122. When you look at her liver enzymes, the aspartate transaminase is in the 6,000s, alanine transaminase in the 5,000s. She also has a coagulopathy. The INR is 9.94. And her lactic acid is elevated at 7. Next slide. So this makes us to the problems that leads to the pathology that leads to problems in the COVID infection. There's a lot of inflammation going on. The inflammation causes vasodilatation. You have a shock state. You have elevated markers that can actually be trended to see how the patient is doing and to guide clinical decision making. Your CRP levels, your LDH, your ferritin, and it also produces an encephalopathy. Interventions include volume, vasopressors, steroids, and anti-infectives. Next slide, please. Next slide. So steroids, my colleague was talking about that, and we'll talk some more about steroids. Dexamethasone has been studied, but you really can use any steroid. So like I say, any son will work. Anti-infectives, empiric treatment for community-acquired pneumonias. If you think it's a more a healthcare-associated pneumonia, you use your medications like meropenem. I've seen that used in Nigeria, antifungals and antivirals. Next slide. So I got some more lab work. The patient's white count is up, higher. It's a stress situation. The platelet count is down to 28. The INR is getting better. The liver function tests are getting better. The shock is improving. Her lactic acid went from 7 to 12 and it's back down to 6.4. Her serum BiCAP is up to 22. Her glucose is higher at 179. This is because we replaced her bicarbonate with a D5W drip in which we mix 3 amps of sodium bicarbonate, 150 milliequivalents, so that we can get an isotonic fluid that will also help with the hypotension. Next slide. So the total cost of equipment so far is about $6,300, 2.5 million naira. But when you look at it in the cost, in the terms of life saving and the fact that a human life is, you cannot put a price on that. I think that one needs to understand that good healthcare is expensive, and we need to drive those who have the ability to, philanthropists, the government, to please invest more in healthcare in the country. Next slide. So another major pathology with COVID is the hypercoagulable state. It causes infractions in various organ systems. A lot of people present with strokes, with heart attacks as a result of the hypercoagulable state. And anticoagulation is actually an important aspect of management that I will defer to my colleague, Dr. Ojioke, to talk a little bit about. So thankfully, our own patient is auto-anticoagulated from the shock liver pathology, understanding that COVID can also directly attack your liver, so it could also be as a result of the COVID infection. But the fact that it's improving with volume resuscitation and treatment of the hypotension suggests it's a shock liver state. So next slide. A couple more questions that were asked, and I think I will defer those to my colleagues. It says, in the resource poor setting, what are the safety precautions for the healthcare workers to prevent contacting COVID? And finally, we've had quite a number of drugs suggested as cures. What's your take on hydroxychloroquine, dexamethasone, and ivermectin? Next slide. So again, I had to rush through the slides. Thank you for listening. And my hope is that we're going to be able to spend more time on answering questions. And that was why I put this slide together. And I await any questions. And again, thank you for staying up and listening to the talk. Thank you.
Thank you, Dr. Makanjuola. So at this point, we'll call Ngozi, who was going to follow it up with some evidence-based discussion on some of the pharmacology and other topics that you presented. So Dr. Ojioke, you can go ahead.
Okay, thank you, Aham. So I will start. Can you hear me? I'm going to use Aham as my soundboard. Can you hear me? Okay.
I can hear you.
All right. So the first thing I'm going to talk about is going to be the anticoagulation. Anybody who is extremely ill enough to be in the critical care unit should be on some sort of anticoagulation. It's usually as prophylactic doses, which is we don't want you to form clots in your legs that might dislodge to your lungs and ultimately cause demise. But COVID presented a different kind of animal. And so we found that in the first month with the autopsies that were done, a lot of patients actually had microvascular events, whether it was in the heart, in the kidneys, everywhere. They were forming these tiny clots that did not allow for blood flow to end organs. And so the question was, do we give all of them anticoagulation at therapeutic doses that potentially could cause complications such as bleeding, including bleeding in the brain? And that is catastrophic bleeding. And so there were 3 clinical trials done across 5 continents in 300 hospitals. So the 3 trials was REMAP-CAP, Active-4, and ATTACC. So they were all looking at anticoagulation. Findings were published December 2020, 2021. And so the conclusion, 2 conclusions. One, using full dose anticoagulation in patients that are admitted to the ICU that are critically ill is not beneficial. It trends to harm unless there is a good reason for it. Good reason, they have a pulmonary embolism, they have DVTs, their D-dimers are super high. Otherwise, your regular DVT prophylaxis in the critical care unit is appropriate and is sufficient. However, in the second group of patients, which are classified as moderately ill patients, they were hospitalized because they required oxygen, not bad enough to be in the ICU. Those ones, if they were anticoagulated therapeutic, that is Lovenox 1 milligram per kilo twice a day, or IV heparin, or a Rextra, Fondaparinux, whatever you use as anticoagulation, therapeutic dosing, it actually reduced mortality, it reduced their admissions into the ICU. So take home point, critically in the ICU, if there's no other reason for full anticoagulations, you don't do that, you just do the regular DVT prophylaxis. However, if they're moderately ill, on the regular floor, telemetry, and they need oxygen, they're moderately sick, those ones are the ones that benefit from therapeutic anticoagulation. So we rest there with anticoagulation. Now, I know there are a lot of questions about ivermectin, so that's the next one I'm going to look at, because it's one of the things that have been brought up again and again in my family and amongst some of my colleagues. In vitro studies, there was positive anti-inflammatory and antiviral properties against SARS-CoV-2, which is the virus that causes COVID. So if you go on this website, it's called ivemeta.com. What they did was they pulled all the studies that they had ever seen on ivermectin and pulled it into a pool and began to do a meta-analysis. However, if you do a proper meta-analysis and a systematic review of those studies, you will find out that observational studies were thrown in the mix. Review studies were thrown in the mix. And so that kind of dilutes your data and the strength of your data. So right now, there are 7 studies going on across the nations of the earth, one in the US, looking at ivermectin. So take home with ivermectin is that the current data does not convincingly encourage the use of ivermectin. However, we have evidence that is accruing. So what I'm saying is, are you going to throw it out the door or out the window? No. But is there a possibility that ivermectin may be used further down the line for COVID? Yes. But do we have enough data to say we're making a recommendation for its use across board? No. So that's ivermectin. The third one is remdesivir, which was actually developed during the Ebola crisis. So remdesivir is not a new medication. It had been there. It didn't quite pan out with Ebola. And so when SARS-CoV-2 came up, they did in vitro studies, and they actually found that remdesivir does have activity against SARS-CoV-2. And so that started out the Act 1 trial. There's now Act 2 and Act 3. And those trials were randomized controlled trials across the nations of the world, again, looking at remdesivir and what it could do for us in the setting of COVID infections. And so what we did find is that just as an editorial, they actually cut short that study early because they were seeing a benefit with remdesivir. So remdesivir reduced the rate of admission into the ICU. It reduced the time to recovery. It reduced the time of hospitalization in patients that had lower respiratory tract infection requiring supplemental oxygen therapy. So it's not for everyone. It is not a cure. However, it reduces morbidity and mortality in the setting of COVID that's severe enough to cause hypoxemia. The problem or the challenge with that study is when you look at the supplement, because that's something that I'm working on right now as a research project, when you look at the supplements attached with remdesivir, only 14% of the patient population were Asian and only 20% of the patient population were Black. So the question is, can we extrapolate this data to involve the nations of the earth, sub-Saharan Africa, Southeast Asia, or do we have to look closer at other people that receive remdesivir in other hospitals across the US and see if this is really enough for us to go ahead and say, hey, this data that we published, you can kind of extrapolate it across board, whether you're Asian, Hispanic, Latino, or Black. The other medication I want to bring up because it's early trials is colchicine. Colchicine we use for gouty arthritis. Right now, there are 2 randomized controlled trials. They're in pre-publication. The preliminary evidence is very supportive, but we cannot currently recommend that you can use colchicine in the setting of COVID. And the reason why I bring up these things is because we may not be able to afford remdesivir in our patient population because of cost and availability. However, things like colchicine, things like ivermectin, we could afford, and maybe those can be part of the armamentarium of the things that we can use to treat our people that obviously in places where we have resource restrictions just because of where we are. The last thing is hydroxychloroquine. In the setting of COVID and SARS-CoV-2, it really should be a dinosaur. We shouldn't be talking about it. We have 7 large randomized controlled trials that have looked at hydroxychloroquine in the setting of COVID, and it hasn't panned out the way we would want it to pan out. Now, I do understand that sometimes we believe in things, but I tell my residents all the time that medicine is not a religion. Medicine is not Jesus. Medicine is an art and a science. So if we have evidence and data out there that support the things we do, we should use it. You can't say, I don't believe in proning, I don't believe in ARDSNet, I don't believe in this, just because in your experience, which has been limited, those things haven't panned out. That's why we do studies. That's why we're involved in research, because the science of medicine we have to take it from the bench and from the clinics into the hospitals and to the bedside of the patient to be able to see the kind of results we want to see. So that, in terms of treatments and what is available, those are the things that we're using right now in terms of medication. So basically it boils down to a steroid called dexamethasone, what you do with the ventilator and oxygenation, anticoagulation, and remdesivir. That's your toolbox in terms of critical care management of COVID and your sickest patients in the ICU setting. Thank you very much for listening. And I'll just hand it back to Gertie and Afam to kind of coordinate the question and answer portion of it.
Okay, thank you so much, Ngozi. And thank you also, Dr. Makanjuola. Very comprehensive discussion and then followed up by Dr. Ojioke giving us the evidence-based input. Of course, we recognize that when trying to make a decision on medications, there's the biological plausibility. Like, does it make sense? In addition, there's our own individual clinical experiences. What have we seen in our own hands? But at the end of the day, we're looking for evidence-based solutions, which then guides us collectively. So thanks a lot, Ngozi, for that input. At this point, I want to welcome everybody who's joined. Understanding that we had some limitations early for some technical glitches, that has been corrected, and the numbers have since swelled beyond 100. So apologies to those who were kept out up till this point, and thanks for joining us. What you missed was a introductory lecture by Dr. Makanjuola relating some basic principles on COVID-19 management and some of his own specific experiences, and that was followed up by Dr. Ojioke providing some evidence-based recommendations on colchicine, hydroxychloroquine, remdesivir, and steroid use. So thanks again, everybody. We will continue to use the chat and address questions as they come. We see a large participant from all parts of Nigeria: Ife, Abuja, Zaria, Ogun State, Imo State, Lagos. So we're very proud to see the reach that this has attained, and it's obviously something that we can continue. What I'd like to do at this point is call Dr. Yemi Johnson, our expert on the Nigeria end. Here, the two speakers, a lot of the questions are coming from the Nigeria end, including how to make decisions on invasive versus non-invasive intubation, decision-making with the use of medications, and how you maintain your consumables. So if you can just take a few minutes and give us some broad insight into your own experience, and then also some feedback from what you've seen and how it relates to what the speakers have presented. We'd appreciate that, Dr. Johnson.
All right, excuse me. Thank you. I actually really did enjoy the two lectures. That was very useful to someone like me. And let me give a bit of my background so you understand how I got into COVID. As most of you know, I am a cardiologist, interventional cardiologist. Never have ever liked infectious disease, never ever. So it's kind of interesting that I got into COVID. But what happened was we saw the COVID going around the world, my partner and I, Dr. Ogunyaki, and we said, this thing is coming here and we better get ready. And we said, okay, what can we do? We said, well, we have an ICU. That's what we do well. And we can get help from our colleagues abroad, infectious disease, pulmonary, and all that. So we reconfigured our ICU, cost a bit of money, kept it separate from the rest of the hospital. Well, a small hospital, 17 beds. So we had 7 beds in the ICU. And we had 7 ventilators and all that. So we configured it, did the IPC protocols and all that. We were helped by a group called DRASA, Dr. Mayo Foundation, who gave us information how to configure the ICU, configure the hospital and all that, including the Lagos state government. So we did that, and sure enough, COVID landed. And I remember telling the people in government as it was coming around that, please, Nigeria, we do not have the capacity to deal with this disease. This thing is going to be a disaster. Shut down the airports, don't let anybody come in until we can figure out how we're going to deal with this. But they told me to go back to my cardiology and mind my business. So I went back to my business. Anyway, this is, in my own experience, the worst disease I've had to deal with in the ICU. It is horrible because we dealt with only ICU patients. So I didn't see the 95 or so percent that got better. For us, we're a private hospital, and we have most of the equipment required. But this is not the case with most of Nigeria. In fact, this is not the case with most of Lagos. Not talk about outside Lagos. Resources are very, very limited. We don't like to use the word resource poor. We use resource limited. Makes us feel a little bit better. But resources are very, very limited in Nigeria. So, but all the standard of care at that time, we followed. And we all learned on the way. And I'm not a pulmonologist. Neither is my partner. We do ICU work, yes. But we were lucky we had Dr. Ishola with us. So there was a team of us. Me, Kofu, Dr. Ishola, Dr. Gunturu from the US, and some other friends from the UK. And we did this kind of conference, Zoom, WhatsApp conference, and they helped us. Each patient we discussed, we decided what to do. Now, what we also did was install cameras on every bed. So we could see, because you have to understand, we have a massive brain drain, massive. All the young doctors and nurses are headed out abroad. We can't keep a doctor for more than maybe a year. They're all going abroad, and I can't say I blame them. I also went abroad, but now they're going out in droves. And so you're there in the ICU. You've got critically ill patients. You've got staff that have never seen a ventilator, never seen an A-line, things like that. So that was also tricky to deal with. But those of us who had an idea what to do in the ICU were all in the so-called high-risk group. And we restricted our going into the ICU as much as we could. But we had to go in when we had to put in a central line or A-line or put the ECMO device cannulas in place and that sort of thing. So we still had to go in. And but the cameras really helped because we would be at home monitoring the cameras, or we'd stay in the office till about 1 a.m., 2 a.m. at night, watching all the monitors, then go to bed, take turns in watching the monitor and taking care of the patients, telling the doctors what to do. Even my wife knew how to read the monitor because she'd see me fall asleep, and then she'd see something flashing red and wake me up, and sure enough, something would be wrong. So that's how we went about it. So it was quite challenging, I must admit, but we had the resources at First Cardiology. Not everybody has those resources. And people were complaining about how much it cost to come to First Cardiology. At that time, remdesivir, 5 doses or 6 doses, cost like 4 million naira.
Wow.
Tocilizumab cost 1.5 million naira. So that's 5 million gone right there, just those 2 drugs. That doesn't include paying the doctors and nurses hazard fee. We doubled and sometimes tripled their salary so they would work in the ICU. Oh, that's the other thing we did. People were scared. So we said, look, if you want to work in the COVID ICU, it's voluntary. You don't have to. It's not, it was voluntary, and most of them volunteered. Some were too scared. The pregnant ones all went home. And that was a really tough time for all of us in Nigeria, especially in healthcare for COVID. We were scared. I was scared. I said, look, all of a sudden I'm high risk. The other day I was doing residency, and now they put me in the high risk group. I didn't quite like that, but that's where we were. And I ended up getting COVID. And I remember the patient that gave me COVID very well, coughing and spitting into our faces, but we got COVID. All of us looking after the COVID patients got COVID in the long run. Luckily, we survived, and we were feeling very good with ourselves, saying we had lifelong immunity, only for you ID guys to start telling us that, no, it might not be lifelong, and making things hard again. But in a nutshell, that's what we went through. Now, Remdesivir is 1.9 million. Tocilizumab is difficult to get, but it's about 500,000 naira. So you can see all these things are expensive. There are three private hospitals looking after COVID, and then one public hospital at Yaba, the IDH, Infectious Disease Hospital, and then Luth. So not many places are equipped to take care of ICU type patients. The isolation centers and all that. Then oxygen is also a challenge. And the state is building a lot of oxygen, what do you call those things? Oxygen plants to make up for this shortage. That's one of the reasons we didn't use high flow nasal cannula. We worked it out on a vent, one of those big tanks, I've forgotten the size, those very huge tanks, last 3 hours. And vent is using maybe 15 or so liters an hour. You can imagine when you're using the high flow, how many tanks you run out of. It just was not possible. So we would go from face mask, non-rebreather, CPAP, and after CPAP, intubate. But the one thing I remember very clearly is of our patients that died, majority of them died from infections. Blood cultures would come back with some bacteria none of us had ever heard of, resistant to everything. And that was a common pattern. So after we saw that pattern, we stopped putting in central lines, stopped putting in arterial lines, stopped putting in Foley catheters unless there was no way out. And after that, our infection rate dropped, but we stopped most invasive procedures and stopped doing blood gases every day. We used to do blood gases once or twice, sometimes 3 times a day. We have all the equipment at the FCC, but like I said, it's a private place and our patients are upscale patients. So it is not the same for my colleagues in the teaching hospitals. Those patients cannot afford anything. They really can't. Government pretty much ran out of money. They tried, the Lagos state government, I know for sure, did a lot of work, treated everybody free, but there's not an endless supply of money. So, and there's only about so much you can do and decide, look, are we going to use all our money on COVID, or do we have to just take our losses and run with it? And I can tell you, COVID mortality rate, what? 2%. Ebola mortality rate was about 70%. The difference was the mortality was different. And at that time, Lagos state government threw all its resources into Ebola because mortality was too high. In this case, if you put yourself in the government position as a policymaker, would you say, look, this thing is killing 2%, maybe 1% of people? All right. It's not, I looked at our mortality data. It didn't really affect Nigeria's mortality data for 2019. Actually, mortality rate actually dropped. So you see, when you look at that thing and you're a policymaker, you've got to decide how much of our resources are we going to put into this thing? When the government calculated how much it would cost to buy vaccines, it came to about 400 billion. The healthcare budget for the year was 450 billion. So you see, we're a very resource constrained environment. And we're lucky this thing is not damaging people like it is in your end of the world. And I have a couple of theories about that. Small non-randomized observational study in our place, everybody that died had very low vitamin D levels. So we all know vitamin D boosts the immune system and all that. So my theory is we have a median age of 19 in Nigeria. So the population is young. There's a steep pyramid. So most of the population is at the base, young people who are generally handle COVID better than the older people. So the younger people are also out in the sun, getting a lot of vitamin D, they exercise, and they're less likely to come down with COVID. The older people don't go out in the sun, don't do any exercise. The immune system is less able to handle this thing. And that's why it hits the older people. But the other funny thing is we had about 10 90-year-olds coming to the ICU. All of them made it. All of them made it with just oxygen, nasal cannula. All of them made it. So my other theory is by the time you get to 90, you fought off so many viruses that COVID is just one of those little insects biting you and you knock it off. So that's my experience in a.
Okay, thanks so much, Dr. Johnson. Interesting that you mentioned that, because I actually had a patient who was 96 who made it. Her son, who was 77, did not. And I'm not quite sure how, how you explain that, but we're still learning as we go along. At this point, I want to encourage all our panelists and any other infectious disease or immunology expert or anyone who's got familiarity with COVID-19 to continue to use the chat. The questions are coming at us at the pace that we will not be able to answer with the amount of time that we have. I'll bring Dr. Johnson back quickly, again, focusing on the Nigeria end. There are a lot of things that we do in the US that probably impossible, including isolation rooms with negative pressure ventilation. Is that something that you considered or you did at all in your ICU?
Sorry, I didn't quite get that question.
With negative pressure isolation.
Oh, yes. We had the engineers configure that for us. And that's what we did in the ICU. Yes.
Okay.
At least to the best of my understanding of it.
Okay, that's helpful. So that's, again, something else that most of Nigeria probably cannot implement. I'll bring Dr. Makanjuola in. Question from the chat pertaining to how you make your decision. You had mentioned infiltrates, diffuse infiltrates in the lungs as a telltale sign for intubation. What other symptoms do you look for? Coughing, for instance, dyspnea, oxygenation levels. How do you really know when a patient is going south beyond diffuse infiltration?
Yeah, I hope you can hear me.
We can hear you.
Yeah. So I didn't want to emphasize so much on the radiography because there is no radiographic feature that it necessitates intubation. It boils down first and foremost to the clinical aspect of medicine, the art of medicine, looking at a patient and knowing they're sick. Most of us can figure out a patient that needs to be intubated right away. What we have noticed, though, is that we try to keep intubation away longer than before, when the first thing we did was to intubate a patient once we saw that they were decompensating. So some of the markers that we will use to decide on intubation of patient, I mean, routinely we put patients these days, I think the practice is more moving towards putting patients on non-invasive, non-intubated methods of control. Some patients will live on BiPAP machine, the non-invasive BiPAP, for days. Before we get to a point, if the patient starts to throw up, for example, then you have no choice. The patient is on maximum BiPAP support, and I'm talking of maximum. We're using inspiratory pressure sometimes as high as 24, 25 on BiPAP. We're setting the rates as high as 30 sometimes, just to try and catch up with the patient's walk of breathing and see if it will get better. But if you have a patient on maximum BiPAP support and 100%, and their O2 sats are in the 80s or 70s, you have no choice. You're going to have to intubate that patient. So I would say clinically, looking at the patient, if you're unable to oxygenate well, despite your maximal non-invasive support, and if the ventilation is also not appropriate, then you have to go to intubation. Finally, and unfortunately, majority of these patients, the ICU got full, the intermediate care unit got full, so they were all on the COVID floor. And unfortunately, the way most of them got intubated was that they suffered cardiac arrest. And we had to go in there as a code blue. And if we were able to resuscitate them, they came to the intensive care unit on a breathing machine.
Okay, thank you.
So I hope I answered the question.
Sure, you did. Dr. Johnson, if you can make some comments on the Nigeria end. We know your own experience at First Cardiology, but broader picture, colleagues in the teaching hospitals, what have you heard, what have you seen perhaps in terms of those patients who are on the brink, dyspnea, hypooxygenation, what are the trends towards intubation and how are those decisions made?
Oh, like everybody else, we We do everything we can not to intubate. Everything we can, because once you intubate, intubating a COVID patient is not beans. It's very complicated. After you intubate and managing the ventilated patient, it's even more complex than you can imagine. So most people who have ICUs, including teaching hospitals, use non-invasive ventilation as much as possible. And we all use proning. And when you have to intubate, you intubate. But I can tell you, in Lagos, it's limited. The number of places that can intubate. It is limited. Teaching hospitals can, IDH can. They have a few ventilators here and there. But then ventilators is one thing. Personnel to manage the ventilators is another thing. To have personnel to manage ventilators 24/7, 7 days a week. I mean, it is difficult. We are limited, and then people go out every day. During the COVID first phase, UK, US were giving them expedited visas to come. Sending special planes to take them away when we needed them. So for those of you that think the US government or UK government is our friend, they're not our friends, not at all. But yes, basically the same. We try and follow what you guys do in the West with our limited resources. That's bottom line. And I think my biggest problem now is ivermectin. Everybody I know is on ivermectin, and they just tell me I'm one of those in the big conspiracy thing. I don't believe ivermectin works and all that. I say, okay, you can take it. There's nothing I can do about it. So we don't have it on our protocol, but we have in notes there saying, if you take ivermectin, we don't have the data to support it yet. It's generally not a dangerous drug, but as we all know, every drug has side effects. Then one thing we have started to do, I don't know if it's right or wrong, is there's limited bed space in the ICU. So what we do is every patient, we don't take ICU patients anymore. We shut it down in October to go back to cardiology. Then we had a fire, and then our inpatient section got burned down. So for some kind of good reason, we haven't been able to take in COVID patients. And I can tell you this, one important part to note is every single one of us who looked after COVID patients had some psychological issues. I remember when the psychiatry people had a webinar for us, a sort of forum, and asked me to speak on our experiences. I asked a doctor, a nurse, and a radiographer to speak, and tell the experiences. Every single one of them cried while they were talking. So the psychological trauma of this disease is actually very, very significant, and we shouldn't overlook it. I was having nightmares. I couldn't sleep. I was calling my psychiatrist friends every day. Look, this thing is taking a toll on me. So that's one thing I'd like to add. It's a stressful disorder. But what I've started to do, trying to avoid admission, is I give everybody a pulse oximeter, check it out. Once it goes below 95, 94, I still get a CT scan. If CT scan shows significant infiltrates and it goes down to 92, I start on steroids. And so far, like I said, it's anecdotal, it's small. So far, those we start on steroids around 92. We don't get to 80. I mean, we don't let you get to 80. We try and avoid that. At 92, we give you oxygen and then start steroids. And so far, all of them have, and this is about 30-something patients so far. In 48 hours, O2 goes back. It might have been going back on its own, but at least it makes us feel we're doing something to break the point where things get go down south.
Okay. Thank you. There's a question from the chat on short and medium-term outcomes of patients who've had COVID. What have you seen among the survivors? Are there any sequelae that they have? And also, maybe Dr. Ojioke can answer the next question after that, which is on anticoagulation for post-COVID. So Dr. Johnson, what sequelae are you seeing to patients who've survived, if any?
Well, like I said, we did ICU, so we had the sick people. Most who had severe infiltrates are limited from a respiratory point of view. We've been experienced with this for about a year now. many don't get back to their previous capacity. Me, I had what they said 30% of my lungs involved. And it's only after about 6 months, I actually got back to normal. I mean, I had difficulty playing golf. I would get tired easily. Walking up the stairs, I would get tired easily. I'm scared of repeating my CT scan. I don't want to see irreversible damage. And then we had many who had myocardial injury. But every single one who had myocardial injury, we cath, and they all had normal coronaries. And luckily, their EFs were preserved. But the people with most damage were those who had psychological, what we call the COVID encephalopathy. I'm not sure how many of them got back to normal, because I'm not a psychiatrist, but we talked to them. They seem to be somewhat off. But the most common thing was the pulmonary restrictions they had.
Thank you. So I'll bring Dr. Ojoke on. Any comments on the role of anticoagulation post-COVID? It's a question from the chat.
Okay, just before I take that question, let me just talk a little bit about what Dr. Johnson said about the pulmonary effects, because I run my pulmonary clinic, and so we are seeing a lot of them come in. I think since COVID and post-COVID, for those who do survive and come back, and we're talking about people who may have been on ECMO. We've talked about people who had to be on the ventilator for 4 or 5 months, and they come back to the clinic. So we are seeing some degree of damage, and most of it is on the arterial alveolar level. And so there's some of them that, like Dr. Johnson said, 6 months, 8 months post-COVID are still struggling in terms of fatigue and respiratory illness, still requiring oxygen. And what he calls the COVID encephalopathy, I call it the COVID head. Some of them are unable to go back to work and function. So some of those things are real. As to how long that is going to last and how much recovery they'll make, I don't think anyone knows yet. And also to speak to what he says about the head. Oh, I'm so sorry. I can't see my.
Oh, did I cause trouble?
It looks like you did.
Can you hear me?
We can hear you, but we can't see you.
I don't know what happened now. It says my video is stopped. Well, you can still hear my voice. So I guess that's good enough. Yeah. So I'm also going to speak to what
it's probably where you are.
About the psychiatric experience. And I know that Dr. McInjola has also. Can you hear me?
Yes, we can.
Yes, now.
Okay, so sorry. So what Dr. Johnson is describing in terms of the psychiatric trauma is it's very real, because I know that there were very dark days. I mean, I never in my career as an intensivist have I ever gone to work and I would sit in my car for 15, 20 minutes, afraid, petrified of walking into the hospital, because I just didn't feel that I could do anything for anyone. It didn't matter what you did, they died. It didn't matter what you did. 22-year-olds. I had a woman who buried a son and a daughter, next door to each other in the ICU. They'll be talking to you, texting on the phone, mouthing words, and literally before your very eyes, you see them deteriorating and you're resuscitating, and there's nothing you can absolutely do. So I think there will be a fallout of that, not just amongst families, I think amongst a lot of healthcare professionals. And I know in our system and in our nation, sometimes mental health is not addressed. But I think this is one of those times that people should seek out therapy and talk to people and just kind of work through this so it doesn't become a problem. So having said that, let me go to the anticoagulation. So there are some parameters that you use for the anticoagulation. Someone asked about how much you use and what you use. Based on the studies that were done, it really didn't matter what you used as long as it was therapeutic anticoagulation, whether it was IV heparin, whether it was sub-Q enoxaparin, sub-Q fondaparinux, and it is therapeutic dosing, the way you would dose for an acute PE or an acute DVT. So it's not everyone that needs therapeutic dosing. Like we said, it's those who were moderately ill. So they had to be sick enough that they were in the hospital. They were hypoxic. which means they were needing supplemental oxygen, 2 liters, 4 liters, whatever it is, you were giving them a supplemental oxygen. They did have the bilateral infiltrate, so they had some pulmonary involvement, lower respiratory tract infections. Those were the ones that would need the therapeutic dosing. Now, the therapeutic dosing, like I said, it didn't matter what you use it, as long as it was an anticoagulant. They didn't study the novel oral anticoagulants, so things like Eliquis, Xarelto were not studied. They were all injectables that were studied in these 3 randomized controlled trials. D-dimers that were elevated depending on what units your place uses. Some people use international units, so whether those who were greater than 3 got therapeutic anticoagulation, less than 3 that they didn't. In my personal practice, I scan all of them in terms of their legs if their D-dimers are elevated, because there are people that were on therapeutic dosing while they were in hospital, they're discharged home, they come back 2 weeks later, massive PE, dead. So in my practice, again, this is not based on data, this is based in my practice. If you were on therapeutic dosing in the hospital, when you leave the hospital, I keep you on oral anticoagulation for at least 30 days. You follow up with me in the hospital, and at that point in time, we review whether there's a necessity to continue anticoagulation. If you did have a DVT or you had a pulmonary embolism, we just follow the normal chest guidelines, which is to anticoagulate you for at least 6 months and then stop. So that's what I do based on the evidence that's out there, and then based on my own personal experience in my practice.
Okay, thank you. And
I hope that answers the question.
It does, thank you. And several people asked the questions pertaining to that, so it's very helpful. While we have you with good reception, can you also comment on your experience with bronchoscopy? We know of a video that went viral about the chap doing it in South Africa. It's not necessarily mainstream anywhere else as far as we know, but patients demand it. What's your experience? And maybe Dr. Makanjuola can also chime in after you.
Okay, so in terms of bronchoscopy, the reason why it's done is because some of these patients actually have very thick secretions. It's almost like forming a cast. You know, you pour cement into a cast and it actually casts the airway. So the idea behind the bronchoscopy is that if you can go in there using mucolytics and a bronchoscope and you can actually clear some of those secretions out, it will help in terms of better gas exchange. Now, have we done it? Yeah, I did a couple in the setting of COVID. But you have to remember that when you have people that are on very high airway pressures, oxygen, you're in a PEEP of 22, 100%, your airway pressures are high. If you put a tube in and you block the tube, you will increase intrathoracic pressure and you're going to cause a pneumothorax. So it has to be a case-by-case basis. It has to be a discussion that's had with the family to understand that, yes, in the process of doing this, this is an experimental therapy. There's nothing out there that says that this works on everyone. We will give it a chance and see if it works. So that is how it's done. And the data has not been published, but it's being done in, at least in Georgia, in 2 healthcare systems where bronchoscopy is part of what's being done for some of the patients, depending on how viscid their secretions are. And if they do think that doing the bronchoscopy and the mucolytic therapy will help in terms of reducing the burden of and the volume of secretions in the airway. So it is being done, it's just not being published as data. And I think somewhere down the line, it is going to be published as observational data or experiential data. But right now, randomized controlled studies, I'm not aware of any that's being done looking at bronchoscopy as a therapeutic intervention for COVID.
Thank you. Anything to add, Dr. Makanjuola?
Not really. It's a procedure that we try to avoid at the beginning, and as more data is coming out, like Dr. Ajioke said, it's actually, we tried it on a couple of patients or so. It didn't make a major impact on their overall outcomes. The investigations in my, what I've had to do in the patient has been patients that have had, for example, complete collapse of a lung, and you just have to go in and get out a mucus plug. And I remember a patient in particular that the balloon on the endotracheal tube, she continued to have an air leak. No matter how high you inflated it, we actually had to change her. She was really sick. So we had to change out the tube and put in a larger size, which we did, and which in literature should solve the problem, but it didn't. And I just used the bronchoscope for guidance during the exchange, and just so we don't lose the airway. And she just had complete necrosis of her trachea, and actually that was the reason she was leaking. So it's not really common a whole lot, and there's no data that tells us to do it right now.
There's a question from the chat pertaining to renal function diminishing after COVID infections. Dr. Johnson, any experience with seeing people have renal function problems afterwards?
Yes, quite a few. And a couple went on to dialysis and still remain on dialysis. Most didn't require dialysis. We did CRT on quite a few of them, but that was mostly for the acidosis and all that. But one thing I did find out is most people whose creatinine went up, it never came back down to baseline. It always stayed up. If you went up to a creatinine of 5, it come back down to 3, but never went back down to normal. That's was my experience. But then we had a few who survived. There's one patient who survived that I told his family, I told his doctor, especially his referring doctor, that look, no way this guy's going to make it, but we'll do our best. Guy came with a pH of 6.9, creatinine of 13, PO2 in the 40s. I said, well, we'll do everything. I said, if he survives, I will go to church. Anyway, the man survived, and they remind me every week to come to church. And as soon as the Zoom church is over, I'll come. But yes, that's what I noticed. The creatinine never went back down to baseline.
Okay, thank you. Well, somebody has his hand up. I'll say, please be patient. We'll get to you. Along this line, I'm going to bring in Gertie. Any experiences that you've seen, or what's the general understanding in the infectious disease community on the impact on the kidneys? It's not something that is widely discussed.
Okay. Can you hear me?
Yes, we can. We can hear you twice.
Yes, we can. Yeah, there's an echo.
Hello?
Yes, better now.
Okay, so the question was any explanation from an infectious disease point of view?
Explanation and experiences. What are you seeing? How does it correlate with what Dr. Johnson just described?
It correlates very well. A lot of the patients that had acute kidney disease ended up, even if they did any better, still had some residual issues. Even some of them that had dialysis, of course, they got better. Some of them, it is just overwhelming weakness that people complain of. I think Dr. Johnson mentioned something. He was describing his symptoms 6 months later. And we've seen a smack load of such patients we're describing as long COVID. People that have had neurological symptoms, including just confusion and fuzziness. I keep telling the story of one of my girlfriends. She's a psychiatrist right here. She got COVID in May. And till today, when we talk, she still tells me she's still not totally recovered because she, a lot of times, is fuzzy. And you've heard of people that have had stroke. I have a few patients that had stroke as a result of COVID and, recovered some, but not totally. There's a lot of people that complain of just not being able to get back to their baseline in terms of breathing wise. They're still somewhat short of breath. The things that they used to do before, like, normal physical activity, like exercise, they just can't get back to that baseline. So it's not only the renal function, it seems to affect a lot of the other organs, especially those organs that have the ACE2 receptors. Of course, that includes the brain, the kidney, the heart, the lungs, and all such. And that's what's constituting the long COVID that we're now talking about. I think in a matter of a few months, we might have a little bit more data out. And this is why I tell people to help themselves to prevent COVID: mitigation. And if you can't do enough of it, if you can get the vaccine, I know it's not in Nigeria yet, but when it comes in, people need to take it, because we don't know how many years the effects of the COVID will last. We're really at the beginning. This is almost like a moving target. We're learning as we go. And so it is very risky for us to, those of us that are in the healthcare profession, we're already an endangered species. It doesn't really matter sometimes how much protection we do. We just, it just happens. But as much as possible, we should be putting out the information out there, especially in the general community. I'm very concerned, very worried about what I see in Nigeria. I see family members still going to parties, doing all kinds of stuff. And when I say, they'll be like, oh, no, it's not over here. We don't have it in Nigeria. And it's just very concerning. I heard Dr. Johnson alluded to the fact that we have a long population. I think that's very true. And I think that might be one of the reasons why COVID, it doesn't seem to kill as many people in Nigeria as possible. But we still think that there's been an uptick of people dying of COVID, especially with this second wave. But I'll be happy to answer any other question on infectious disease. For now, I'm going to let the pulmonologists, answer the pulmonary questions. Thank you.
Okay, thank you, Getty. Getty is known to be in multiple places at the same time, and you can see from the Zoom that she is in San Francisco and also in her home office at the same time. I'll bring Simon Peter, who's had his hand up for a while, to make some comment. It's interesting you say that people get fuzzy after COVID, Getty, and people have been saying that maybe that's what happened to Trump with the fuzziness after. All right, Simon Peter, you had your hand. Thanks for your patience.
Okay, yeah, thank you very much for giving me this opportunity, and thank you for organizing this conference. You were wondering, a pediatrician, and what am I doing in COVID? Because I think the world over, they think it's not a disease of the children. Anyway, I happen to be one of the members of the response team in Federal Medical Center Makurdi, so I had to deal with adults, not only pediatrics. I just want to kind of like collaborate with some of the things Dr. Johnson has said. Thank you very much. As a private practitioner, we are in the government and we see a lot of that. You see, why I was co-opted into that team was because I did my residency in South Africa. And I happened to be, in fact, one of among in the center who had good knowledge of ventilators and, kind of like managing patients who are on ventilator and the rest, because even the anesthetic, some of the people who work here, some of them have not even seen ventilators. I'm telling you, it's very true. I'm not exaggerating. There are consultants here. Some of them have not seen some of the ventilators. So, and then when the management wanted to get in ventilators, they had to bring me in. And, some of them, like, as we are saying, machines for arterial blood gases, some of them even don't know how to use it. So that was why I brought it, because my training there gave me the opportunity to use these things over the 6 years I was there in South Africa. And I just want to also to agree, the manpower is a very big problem. And that was why we also in our center decided not to kind of like rush to, intubating patients, putting them on the ventilator. I just want to say that, I don't know, but I'm putting this also out like a question. When this COVID pandemic first started, we had an issue of temperatures being on our own side here in Nigeria. I don't know whether you guys still think that is also one of the possibilities that our disease burden here a bit light, and it's not as severe as what we are seeing in other diseases. Because in terms of prevention mechanism, I think it's really not being done. People don't even use masks. People don't even do most of those things. But why are we still at that low level? I think maybe there may be these environmental factors too that are contributing to it. And we have not seen unusual deaths. As soon as say, okay, maybe there are those deaths that they are not recording them, or just as Dr. Johnson said. It has not actually added to our mortality. We have not seen unusual deaths as we would have expected, because these things are not being done, and then those things are happening. Actually, I'm also a survivor of COVID. I actually didn't even know I had COVID because I was sick for 2 weeks, and I didn't know. I did every test. Nothing was showing. Every result was normal. And I actually didn't have respiratory symptoms. So I just decided to just do the screening. And lo and behold, it came out I was positive. This has already been like 2 weeks ill. So I don't know, but I think maybe on our own part here, maybe environmental factors are helping. Maybe the young population we have is also part of it, and the rest. But what I just want to say is that it's actually challenging in terms of some of those things that you guys do over there. We're doing it here. So what we actually are doing is we are trying to mitigate, we are trying to prevent as much as we can. And the use of Ivermectin, as Dr. Johnson said, he is not actually a supporter of that. But I think a lot of people are taking it, and it seems maybe it's helping. So to us, we are using it here in our center. It's part of our protocol, and we're using it here. Thank you very much.
Thank you, Simon.
Sorry, Aham, could I just answer that question, if you can hear me?
Sure.
Yeah, and the piece of it that I want to mention is this idea that we don't have the disease like they're seeing out in the US. And I just want to echo what Gertie said about this disease being a moving thing. When we first got COVID, the first surge of COVID in the US, the African American population said that we don't get COVID. And I don't know if you all remember that. And so there was this idea that it was hitting the Caucasian population a little more. The Northeast, New York had it, Florida and California didn't feel like they would get it. By the time we got the second surge, the African American population was hit like never before, and mortality was highest there. As we were beginning to have numbers drop in Georgia, California got hit like they never thought they would get hit. So I think we should be very careful in playing down the severity of this disease, because when it happened in China, everywhere else in the world, we didn't think we were going to get it. We've had a second wave in Europe that appears to be more devastating than the first wave. So I still think we should assume that this disease affects everyone, mitigate, get the vaccine when it's available, wear your mask, do all the things that we need to do, because we certainly do not want to see a surge in Nigeria like we may have seen in other parts of the US, because we do not have the resources to be able to do what we need to do to save those lives. So I don't want us to settle in a false hope and this false sense of security, because I don't think we've seen the last of this virus. And it's just a word of caution. That's all I'm doing here, is just a word of caution that we should keep staying safe and doing what we need to do to stay safe, because people have said it doesn't hit us. And when it hit very badly. So I just wanted to add that before his other questions were answered.
Okay, thanks for that input. Yeah, and I think most of us would agree it's difficult to draw firm conclusions now. We're all very grateful for whatever the reason is that it hasn't had the same devastation in Nigeria as we've seen here in the US. But the chapter is not finished. The book is not finished, certainly. So we'll see. In South Africa, they've had variants. There might be a Nigerian variant. Anecdotally, it seems like there is a surge to some extent, at least in the medical community. More doctors seem to have died in the last 2 months than prior. What inferences we can make from that, not sure yet. Simon had expressed his experience in Makurdi. One of the questions in the chat was, what are the issues with PPEs? This is from Dr. Bamboye. Issues with PPEs in Nigeria. How easy is it to acquire? Are there still challenges on that end? And then secondly, Simon, very quickly, if you don't mind, you're the one among our people who've spoken up today, only one who's mentioned ivermectin, and multiple questions on what dosages are recommended for prophylaxis and for treatment. You could just share your experience. We all understand it's not evidence-based, based on the current evidence. So quick question on PPEs and then your own experience with ivermectin recommendation for those who keep asking. Thank you.
Okay, thank you very much. PPEs is actually a very big problem. The federal government has tried. There was a time we had them enough, but after a while, the pool got dried, and we're still expecting them to come. But as I'm telling you, yes, within the isolation centers, is Federal Medical Center and the Benue State University Teaching Hospital. Within the isolation centers, at least we have the ones for the staff working in there. But in the terms of in general hospital setting, patients, hospital staff attending to patients. Because one thing we just have to believe, or we just have to know is this: COVID is not written on the face. You don't know when you are dealing with a COVID patient or you're not dealing with a COVID patient until maybe the symptoms, the symptomatology, and then you test that patient before you know. So in the general hospital setting, yes, there are no PPE. I won't lie to you. Patients, doctors, nurses have to buy their own face masks or use whatever thing they can get to cover their nose when they are working in the hospital. But at least at the isolation centers, yes, the government is trying to provide there where those doctors who are directly working with the already known COVID patients, to use. That I can say they are trying to get us some now, where it's not as bad as it first started on that. The Ivermectin, the dose we are using here, like for prophylaxis, all they're using is 12 milligram. Let me check the protocol quickly. I don't want to give you something that is wrong.
Okay, no problem. What you can do is put it in the chat.
Yes, I'll put it on the chat. Yes,
yeah, put it on the
because
chat.
it varies. So I will just check and then I will give it.
Okay, and if there's an online reference that you can recommend for those who wanted to find out.
Yes, I'll put that on the chat. We have some studies that we have that we use to prepare our protocol with.
Okay, that'll be very helpful.
Okay. I'll put it on the chat. Thank you.
All right. So we're now at 4 o'clock. Considering we started late, we're willing to keep going, but we want to be very respectful of everyone's time, particularly those in Nigeria. It's later on that end than it is on this end. And then some of our folk here want to get ready for the Super Bowl. But at the end of the day, we want to have a robust discussion and cover as much as we can. So we can keep going for a few more minutes, and then we'll see how that looks. It's an opportunity to circle back. I'm sorry, Dr. Johnson, you could go ahead.
Okay, let me just say something about malaria and COVID. Because malaria hasn't gone away. Everybody thinks everything is COVID now, but malaria hasn't gone away. And I have found that a lot of patients, especially those with high fevers, tend to have malaria as well. And the malaria doesn't respond to the routine treatment. You tend to have to treat it for a longer period of time for body to get rid of it. So that's one note about malaria I have noticed. It is still present, and not every fever is COVID. In fact, most of the COVID patients I know don't get the fever. So all this going around everywhere with the thermometer, to me, is a bunch of BS. But malaria does happen in COVID, and it is more difficult to treat.
Okay, thank you. That's helpful. So I want to somewhat circle back to the pulmonary ICU part of things. In terms of hemodynamic stability and monitoring, Dr. Johnson, perhaps you can let us know what are your experiences with using pressure support and vasopressin, epinephrine, and whatnot in these patients, and how much of a challenge is it in the Nigeria setting? I'll let Dr. Johnson answer, and then Anthony Owak, who has his hand up, can have some time.
Okay, well, we unfortunately had to use those drugs quite a bit. Many of them will come to the ICU. Once you intubate them, you're going to use pressors most of the time. You're just going to have to use pressors because you got to use heavy sedation and sometimes paralyze the patient. So you end up using pressors, which I don't like, but my intensivist colleagues seem to like a lot, and they just use them like it's water. But we have them available at our place. We use epi, we use noradrenaline, and we use vasopressin. We use all of them. And but the more pressors they're on, generally the worse the prognosis. So we try and minimize sedation as much as possible so we don't have to use the pressors, because the pressors have their own negative effects on the kidneys, make the heart function, especially those in heart failure. It makes it a bit complicated. But yes, we have to use pressors. And like I said, once you're using pressors, you're on the vent, you've got a central line, we're checking your CVP and all that. Things don't always wind up nicely.
Good point. Okay, Anthony, you can unmute your mic and ask your question. Anthony Owa.
Yeah, okay. Just a few quick comments. Having survived COVID twice within a very short period of time, and that's confirmed. Yes, the fever is just, it doesn't always occur in everybody, because when I did have it, I didn't actually have a fever, but I did feel like if I had malaria-type symptoms. Going to the Nigerian situation, I actually think just like everywhere in the world where there's not widespread spreading and widespread testing, it's actually an underestimate of the real figures that are going around the country, because I even note that when I visited Nigeria in December to see a few cases, I did see people on the street, being fanned furiously by their colleagues with obviously high temperatures or being fanned in daylight on the third mainland bridge, coughing away. So I don't think it's gone away. I don't think it's actually just a blessing in disguise that we're not hit. I think we're hit, but we just don't know how hard we're being hit in Nigeria.
This thing where they watch you.
Hello? Hello? Am I still on?
Keep going. There was background noise.
Okay. And the thing about temperature, Ecuador and other countries like that have the similar type of temperature terrain that we have in Nigeria, and they were hit badly. So I don't think temperature has much to do with it. Vitamin D might be a factor. And I just also worry about people using ivermectin without any concrete evidence that it can help with prophylaxis. It's one thing if you're in a resource-challenged environment and you're using ivermectin because there's no evidence against it per se, at least from the NIH comments, that we're withdrawing the objection and now it's neutral, which suggests it might have an impact. Is another thing to use as a prophylaxis, because most people are getting better using their own immunity, which the vaccines aim to do. The vaccine is just basically something that's going to help improve your defense against it rather than being virucidal. So I just wonder the rationale behind wanting to use it as prophylaxis when it may not actually stop the virus from happening in the first place, especially as it continues to mutate. I think that's just important to nothing. It's one thing, like I said, for treatment. It's another thing in terms of it being used for prophylaxis when it's not proven. Those are my own quick comments.
Okay, thank you. So obviously, there's going to be a lot of explanations out there on why Nigeria is hit less hard. Probably allows us the luxury of trying things like ivermectin, which the West has turned its back on. The WHO just this week came up with some updated recommendations and declined to include ivermectin. Similarly, Merck on Thursday, the actual manufacturer of ivermectin, put out a very strong statement discouraging it. Of course, era of conspiracy theories, people now suspect that Merck may have some other secondary gain, but the evidence across the board doesn't seem to support it. Fortunately, it's a safe drug, it's cheap, it's widely available, and with the absence of any good options, then people feel they might as well try, and hopefully the data will come out later and guide us better. I'll allow David, who also had his hand up, to make some comment or a question for the panelists. David, you can unmute your mic and ask your question.
Can you hear?
Yes, we can. You can introduce yourself too.
I've got a vested interest. My brother is one of the people on your panel, so it's I just said it was very good to be on this platform. Love what I've been hearing. There's just Dr. Ojoke mentioned, and I think it's quite right, don't let our guard down. But again, I go back to Dr. Johnson. What you're seeing on the ground is actually not people dying in droves in the streets. And yet in America, there is a significant problem. And part of me just thinks it might be trying to tell us something about COVID. We're on the risk of looking to America, the UK, the West to learn how to treat this disease. It may well be doing something different in Nigeria, which actually tells us much more about it. And I just think it'd be a missed opportunity if people there aren't actually looking and saying, but why is this different? It could tell us something pretty big about it. We heard just from the previous speaker, it's not a temperature thing. There are people on the same latitude who aren't falling like flies in other parts. It's not a black thing. You get to America and you seem to be much more exposed, much more likely to do badly. But they're not falling like flies in Nigeria. Now, Dr. Ojoke again might be right. It might be a question of time. Please don't become complacent. But I just listened to what Dr. Johnson's saying and the people on the ground. It might be a different beast there, and it might actually help us to learn something about this virus.
Yeah. Thank you for the comment. Who's your brother?
Dr. Makonjola.
Okay, welcome. So yeah, I mean, the jury is still out, obviously. We have so many theories out there. I had one that COVID may already had a cousin that went through the Nigerian population or the sub-Saharan African population at some point that perhaps wasn't as infectious as COVID-19 and therefore created some level of immunity. We recognize that people who get it a second time don't seem to have it as bad as people who've had it the first time. And very few people actually get it a second time. So, hopefully with proper epidemiology and other research, we will have some answers to that. We can keep taking people whose hands are up.
I just think it's fair because we still have quite a number of people on this other second channel. We have about 40 people here and they've been asking some questions. I'm going to just take, I'm going to take two and I'm going to make it into one. Mr. Yusuf Oluwaseun Yakub said, sir, for those you started on steroid based on the pulmonary infiltrates on chest CT, do you get a repeat chest CT despite negative test? And how soon do you get the repeat chest CT? And then the second question is, second question is the fact that half of the population of Nigeria less than age 19 years has been a part of, for which it had not been as bad in Nigeria, as the younger group are able to ward off the disease than older age groups with multiple comorbidities. Thank you. That question, I think, is for Dr. Johnson.
And I forgot the first question. Can you remember what the first question was?
About when you give people CT steroid after their CT scan.
Yes. Okay, I remember now. Okay. Actually, yes. We do repeat the CT scan in quite a few people. And I'm happy to say in most people, the degree of infiltration is much less, like 6 weeks after. The degree of inflammation is much less. And so why it's much less, I don't know if it's the steroids or if it's just the body healing itself, but it's much less. And yes, I think our young population is protecting us, so to speak, from the high mortality. It's one of the factors. Now, don't get me wrong, there is a second surge, no doubt, which is, at least from our numbers, twice as bad as the first. As far as numbers go, there is a second surge and people are dying. They're not dying, but the number of people dying, when you look at the COVID deaths, in Lagos, 630 people die every day, period, COVID or no COVID. So when you have 10 or 15 at a to that, it doesn't make much of an impact, and that's just Lagos. And I've spoken to the funeral homes, I've spoken to many people who are involved in funerals. There isn't that much of a difference. And I really don't know why. I really don't know why. But, you know, I remember the case in Kano when they were saying about 800 people were dying every day in Kano, there's something going wrong. We went and looked at the figures, and that's generally how many people die a day in Kano. So, you know, there is a mortality to this thing in Nigeria, but it's just not hitting us the same way it hit someone like Venezuela, where they were finding people on the streets and they have the same temperature and everything as we do. So I don't know what it is. I don't know. But there is something a bit different about ours. I hope it stays that way.
Mm-hmm.
Okay.
Aham, over to you.
Okay, so I'll call on someone who's had his hand up for a while. Folaring Apawoye. You can unmute your mic and ask.
Okay, thank you very much. Doing a very robust discussion. I work in infectious diseases in Louth, and we have an isolation center there. And I think it's just really, we have to really be careful, because just like Dr. Johnson said, we've had a bad second wave. And there's a problem with how some of the deaths that are officially reported, because generally they like to report only confirmed cases. So because of a dearth of testing, I mean, you have a patient coming in with a saturation of 40 before you take samples, patient is dead. It's not all times you're taking post-mortem samples. Because of the way most of the reports are done in Nigeria, that's called a suspected death, even though all the signs point to COVID. Over the last, from December to January, we have been able to lull now in terms of the pressure on admission and the deaths. But there was a particular week. In that week, we lost a 38-year-old. We lost a 37-year-old, 2 of them actually. One of them without any known comorbidity. We lost a 34-year-old, 52, 53. We lost a 28-year-old who was pregnant. So it's really been bad, this second wave. Again, it may not be as bad as what's going on in other countries, but at some point, almost everybody knew somebody who was sick or had died from COVID. And we were recording some of the isolation centers up to 5 to 7 deaths on a daily basis. Not all these deaths eventually get up to the life scores produced by NCDC every night, but that doesn't mean that we should discount that, because every mortality is 100% to the family that is involved. So a lot of people died. Things are getting a bit better. I've gotten a bit better in the last 1 week. Unfortunately for me, I think there may still be another wave, in so much as we don't get the vaccines on time. But the reality is that things are not as clean as we may want it to be. Thank you very much.
Okay, thank you. It's also interesting that we're starting to see variants. And one of the things we recognize is that this virus, as it replicates, it produces errors, it mutates. Some of those variants could make it more infectious or make it more deadly. And it turns out that the more people are able to survive with COVID, the better the chance that they can replicate and then create mutations. So we hope and pray that that doesn't imply that the survival rate in Nigeria eventually can lead to a potential more lethal variant. So we still, as everybody else has pointed out, need to be as careful as we can be, and hopefully get a vaccine solution to really get ahead of it. Dr. Makanjuola, you were in Nigeria recently. I want to bring you back in. You've been out of the loop for a while. Just some comments on explanations for the low rates in Nigeria in comparison to the West. And then after that, Mr. Ide or Mr. Ide will have a chance to make some comments.
Yeah, thanks for bringing me back. I will piggyback on what our colleague said earlier from, I think, Makodi was. I think the generally young age of the population is a major factor. And it's not only in Nigeria, in a lot of African countries, the median age of the population is so young that definitely they are able to ward off the disease more than others. Having said so, as I said in my talk, I just find it hard to believe that a country 2/3 of the population of the US has 1,600 people dead from COVID. And I think what the infectious disease physician from Luth just said is probably right, that there is something wrong with the data collection. More people are dying, and I don't know. Maybe we might never find out. I still find it hard to believe that people are not dying as much from the disease. I've had family members infected in Nigeria. There's hardly a friend of mine who has a family in Nigeria that hasn't had a family member infected, and there have been some bad adverse outcomes. So where's all this data? Where are all these people? That would be my comment.
Okay, thank you. So there was a recent study in the US here that seems to indicate that the numbers are actually underreported by 3 to 4 times. So the numbers of infections in the US might be 3 to 4 times higher. So you can imagine if that's the case in the US, Nigeria, there's a factor, a multitude that is probably higher, both in terms of the number of infections and the number of deaths. There was also a recent study in Zambia that one of our speakers on yesterday's presentation presented, where they did autopsies. They did PCR tests on people who had died randomly, and they found that 20% of them had COVID that was not reported. So again, you can make inferences into Nigeria from some of that data, and probably most of us, including Dr. Johnson, would agree that the numbers are probably somewhat higher than what's reported, but perhaps much lower than what we're seeing in the West.
Let me jump in there. You know, there's a recent study from South Africa. They just did a COVID test on all the dead patients. And they found out that, and those are dead patients that did not have COVID as a diagnosis. They found out that 20% of those patients had COVID. That's 1 in every 5. So we should think about it. If we make that extrapolation, these are people that were dead, were never diagnosed of COVID, and they at the time of mortality, and it was shown that they had 20% of people positive. So that's really something that we all need to look at. And I wish that we had more data coming out from Nigeria so we could see. I'm not sure who's sharing this.
Okay,
Latisha?
Simon, I'm sorry, Simon Peter. Yeah, what we had asked was to put it in the chat.
Well, this is the stuff from the FLCCC people from right here in the US. The guy that gave the talk at the Senate, the US Senate, this is that group. We've seen this. I don't know if you guys are using this in Nigeria. We're not using it here because we don't have the data to back it up. This is the group and they, you know, unfortunately, this stuff has been made unnecessarily political. COVID does not know what politics we have, what race we are. I really don't agree with sharing this here. Like this is an information that ANPA is behind, because we want data that is supported by evidence. And this is not, Dr. Ojioke described, this is part of stuff she was describing, where they got their study from. Some of them are investigational, some of them are retrospective. The studies are cohorts. Okay, so for instance, the one that was done in Luth, I think that it was a very well-designed study, double-blind, placebo-controlled, randomized study, but it was only 62 patients they had. So if you divide those 62 patients to their 3 groups, which is placebo, 6 milligram and 12 milligram, you get an average of 20 patients in each group. In this part of the world, nobody is going to make any recommendation based on that. It's not because of the design of the study, it's because of the amount of people in that study. Now, if you get a conglomeration of studies of maybe 62 patients here, 100 patients there, and all, and you add it up and you're making it to be 4,000, that's not true. That's not how a good study is done. And we may find out that ivermectin may work. Merck produces ivermectin, so it should be in their interest to say, yeah, use ivermectin. They came out with a strong statement this week and say they do not encourage it at all. So until we have a larger study that is showing that this stuff is a fact, I would say it right here that if anybody wants to use it, they can use it, but that's not something that we are behind as at this time. Thank you.
Yeah, thank you very much. I agree with you that the strength of the study is limited. But you know, it's just because he asked me to share if we have any document that we use to guide our protocol. That's why I'm sharing. Even during our team discussion, I actually pointed out that based on what these people are showing, the strength of the study is actually limited. Understand? But I think that was what they based as on, and they were using it to kind of like for the prophylaxis for Ivermectin. Thank you.
Thank you. Thank you very much.
Yeah.
So it obviously remains an area of controversy, and hopefully more data will come out. But the better studies so far don't seem to indicate that it has the benefit that is being championed in Nigeria. There are a lot of anecdotal reports, and generally in medicine, as we know, that's a lower level of evidence than other options. Okay, Getty, how are we doing with time? It's 4:30 now. This, by the way,
I think we have essentially paid back the time. So,
right. So maybe what we can do is allow our panelists to have any final comments.
Okay.
And then we can allow Dr. Bamboye, who's the infectious disease chair, to make some comments. Sorry, Dr. Bamboye can make some comments, and then we can wrap up there. So, the speaker, Dr. Makanjola, can go first.
Well, thank you very much, everyone, for staying up. I would like to say I've learned more than I probably have imparted in trying to understand the challenges in Nigeria and the possible solutions. Dr. Johnson, in particular, I learned a lot from what you said and challenges you face, and we'd like to thank you for all you do over there. Hopefully, we'll be able to also join forces going forward. The solution to healthcare in Nigeria is going to be joining forces together and getting perhaps more money spent in the healthcare sector. So thank you, everyone, for staying up and for teaching me today. Thank you.
Thanks for your time and your patience. Dr. Ojoke.
Okay, just in the same vein as my colleague, I have truly learned a lot, and it's just been great being able to interact with my colleagues in Nigeria as well. Dr. Johnson, thank you very much for all that you guys have done. Also, the doctor from Luth, thank you for what you guys are doing there as well. And I also thank ANPA for creating this platform, because it's really been very interactive and very educational for me. But again, just a word of caution, I just want us to say, stay safe as much as possible. Build up your immune system. Let's not let our guard down. And Dr. Johnson, I think it would be very interesting if we're all able to collate some of these experiences and even if it's just an Excel spreadsheet, just to see if we can start getting a body of evidence and data out of Nigeria that might be able to help. Because I think that too will kind of help in terms of what we're doing with COVID and other disease processes as they begin to arise, out of Nigeria too. But once again, thank you guys so very much. It's been absolutely an honor and a pleasure.
Thank you. And Dr. Johnson.
Yes, thank you. I don't have much else to say. I have learned quite a bit from this panel discussion. This was very, very good for me. And I hope a lot of my doctors from First Cardiology tuned in, but I think they might have tuned in that time. There was a glitch. But we all learned a lot, and happy ANPA put up this program. Thank you very much. I have two questions. One, to you ID people like us who have had the disease, and you guys are recommending we take the vaccine. Has there been any study using people like us and determining whether the vaccine would hurt us or help us? Because sometimes I worry that the vaccine might give us a more aggressive immune response to the virus and cause more trouble. It's just something I thought about. Then two, what do you think about false positive PCRs? Because in my opinion, there's quite a bit of false positive PCRs. I can't quantify it, but you have positive PCR, you do the antigen test, it's negative. You do the antibody test, it's negative. You check for the CT scan, negative, no symptoms, just that PCR. And I wonder, I don't think that test, I've read up on the PCR, there's no gold standard to measure it up against. So what do you think about false positive PCRs and then people like us getting vaccinated?
Okay, so false positive PCR is a known fact, and I think it's just by the way of the design of the test. The polymerase chain reaction is designed in such a way that if there's a tiny little bit of anything like that looks like that protein, it will replicate it so many times that it will be able to capture it to produce. So sometimes you can have false positive. Sometimes also the PCR might be positive and the antibody is negative. It doesn't mean that the PCR is false positive. What it means is that because it takes at least 5 days to 7 days for us to produce antibodies. So if, say, somebody was just exposed 2-3 days ago, they are more likely to get a positive PCR, a negative antigen, and a negative antibody. I want you to recognize that. So if you see a positive PCR, I still think that you should take it seriously because it takes the antibodies time to build up to be able to be traced in the blood. And the antigen test is less, it's not as much of a gold standard as the PCR test. The PCR test can magnify any little bit of particle of that virus that it captures. So most of them may still be positive and not false positive. To the second question about COVID vaccination, there is no study right now to show that if you've gotten COVID, you should not or you should take the vaccine. The recommendations we're making right now is based on the fact that we have had patients who have had COVID and then a few months later have another episode of COVID. I've had quite a number. I would say maybe at least 5, if not more. And one of them actually is the last one. She had COVID at the end of November, and by January, she was having COVID again. And this time, the COVID was even more serious. So my thinking is that it's probably 2 different strains that she had. And with all the newer strains that are coming now, because of all the replication of the virus that persists in our community, the way we see it is that it doesn't harm to get the vaccine. At this time, we do not even know if the vaccine works better. I'm trying to mute somebody whose volume is. So at this time, we do not know if the natural immunity is better than the vaccine, the immunity from the vaccine, or if the immunity from the vaccine is better than natural immunity. We're just advising everybody to take it because we think that at least you get more protection until we have enough data to say, okay, maybe we shouldn't do this or maybe we should do that. Thanks.
Okay. I can also make a comment, Dr. Johnson, as I had COVID in April, in the early part of the pandemic here in Washington, D.C. I felt relatively immune. A lot of the initial data did not seem to indicate that people were getting it the second time. Subsequently, we started seeing a few people who came back with second positive tests, not necessarily infections. So that obviously was concerning. And I talked to some of my colleagues in the ER, and around November, December, they started reporting more and more second occurrences, and most of them were not that sick. So it still felt like to some extent there was some protection. Then in December, when the 2 vaccines in the US got FDA approval, they started offering it to healthcare workers, including myself. So I had the opportunity, but I wanted to do my research and be sure. So similar to you, I was a little bit unsure as to what would happen. I haven't had it before. And so I did some reading, and it seems that, as Gertie has pointed out, there's really no guiding data out there. But what they found is that the immune response measured by antibodies, not T cells or anything else, but antibodies, was higher with people who had had the vaccine than people who had had natural COVID. The immunological assays seem to indicate that the virus having had the virus gives you a broader array of antibodies than the vaccine. It's a little bit narrower. So my own conclusion was it doesn't hurt. It probably helps. I probably have some broad array from my own exposure, as well as a boost from having had the vaccine. Even though the data is not guiding, the data seems to show that it's safe. And the CDC, the Center for Disease Control, recently recommended that people who've had it should still get it, but they should wait 90 days from symptoms before getting it. So I felt there's more to gain in my case than to lose. And that's why I went ahead and got it, but I didn't rush to getting it. At this point, we can wrap up. Thanks again for your patience. Apologies again for the glitches. This appears to have been well received. On the chats, you've seen a lot of calls for us to do this again. The Infectious Disease Committee, led by of ANPA, led by Getty, would take that to heart and see how we can engage everybody, our panelists and others, and perhaps some subsequent discussions such as this. We all recognize that it's a continuous evolving discussion. You know, we're now talking about vaccines. At some point, we're going to be looking at the response from the vaccines. In the US, we're still worried about opening schools and whatnot, travel, and as some communities get the vaccine more than others, what are the implications of a portion of the planet having high levels of vaccines and a different portion not having it? So there's obviously a lot to discuss. And ANPA looks forward to being in the thick of it and engaging our colleagues on the Nigeria end and putting heads together to, you know, be updated as much as we can, and therefore service the larger Nigerian community. So thanks again for your participation. We'll have some closing remarks by Dr. Bamboye, and then we will call it a night. Thanks.
Sir, can I ask a question before the closing remarks? Please.
Getty, what do you think?
A quick one. So I was just wondering regarding the Ivermectin, those in Nigeria that their resources are limited, to say the least, what is the harm of them taking it as a prevention or early treatment if they diagnose? The governor of Lagos State has said any malaria symptoms should be treated as COVID. How do you guys respond to that?
I think I should let Dr. Johnson, do you have I mean, I have my take. Being that I am here in the US, so whatever I say is from my perspective here. At the end of the day, I know that we have a resource poor setting in our environment. And if it is not posing that much of a risk, because like you said, we don't have too many other alternatives. It's just that we don't have enough data to recommend it. But I do not go out there and forcefully push against it. If people feel good that they're gonna take it and it's gonna help, sometimes, you know, the placebo effect can work. What I do want everybody to remember is that here in the States and in the Western world, COVID-19, 81% of the patients may not need hospitalization or any extra medical care. About 19% proceeds to probably get admitted, and out of that, about 5% get admitted in the ICU. So you see, overwhelmingly, majority of the patients will be fine, regardless of what we do. In Nigeria, where we're talking about a younger population, I am thinking that number might actually be skewed to the higher side of more people that get COVID may actually not need hospitalization. So if I don't see, the only risk that I see with ivermectin is for people that have lower. If they take it and there is a hyperinflammation, they might can end up with a very high immune reconstitution going on, which might become a problem. But I think that would be like in rare cases. So I'm just sitting down in the middle. I don't recommend it, but I don't speak particularly against it, especially in Nigeria. Thanks. I think Dr. Johnson might have something to say.
I have something to say.
Okay, let Dr. Johnson, who was called, go first, and then in the interest of time, we'll wind down. But we've opened Pandora's box to a small extent. Let Dr. Johnson respond as Dr. Getty called on him. Dr. Dorothy Orode, who is in Lagos, has her hand up. If everybody can promise to keep it brief, then we would really appreciate it. So Dr. Johnson, then Dr. Obioha, and then, I'm sorry, then Dr. Orode, then Dr. Obioha.
Oh, mine is easy. I go with Dr. Gertie. That's easy.
All right, Orode.
Thank you very much, everyone, for your presentations. I just want to say that the reason why we have a policy around malaria management is because we needed one. So if you think somebody has malaria, you should test before you treat. You don't have to treat everyone. And the policy remains that we should test before treating. So I don't think government should interfere with what scientists have worked on. But it's important that everybody who has malaria-like symptoms should definitely get a COVID test. And I think that's important. But also, so also should everybody who has a non-specific symptoms. The issue we have is we don't have enough tests, and that should be made more available. Thank you.
Dr. Orode, they don't know who you are. Just a quick intro.
My name is Orode Duarte. I'm a pediatrician, and I run primary healthcare franchises in Lagos.
Thank you. So Dr. Obioha will be our last person, and then we'll have our closing remarks.
Okay, yeah, I'll try and make it very brief. I'm glad I'm here. I happen to be in Nigeria now, and after practicing in the US for a long time, I think we have a problem in the US by thinking that everything must be proven to the T. Look at the number of people that died there. Anyway, my little experience in Lagos is that patients who have COVID, even according to the NCDC, Professor Mujishola, she said we should actually use hydroxychloroquine early or even for prophylaxis. I have noticed that early intervention actually does help a lot with COVID. It really does help a lot. And patients have responded. My son got COVID in the US. Fortunately, they didn't admit him. They had him isolated. I went behind and had my brother prescribe all our Nigerian stuff for him, and now he's doing well. I was so scared of that boy being admitted because he's a big black boy. We are taking too many chances in the United States, but that's how things are there. Merck made the statement, but you don't know if Merck is coming out with something, and Ivermectin is so cheap. Why would they want to even promote it in the first place? So we don't know. So we have to do what we have to do, and people are doing well with those things. And I agree with Dr. Yemi Johnson. We have a young population. We eat food from outside everywhere, very organic food. People are very strong. They walk long distances and so on. And so I think they have a better overall immune system, and it has been protecting them. So fortunately, we don't have it as bad as it is overseas. We're very fortunate.
Okay, well, thank you. I mean, this discussion can go on and on and on, and we can make all kinds of inferences. And the reason why the US doctors generally embrace a evidence-based approach is because that tends to be the best way to reproduce results. Having said that, we know it's not purely immunity because our children are not getting it, toddlers are not getting it, newborns are not getting it. If it was purely immunity, then we would have children getting it as well as elderly people. So we can all accept that we don't really fully understand the full picture and continue to gather data as we go along, including on the Nigeria end. If we can gather as much data as possible there, then we can perhaps have some Nigeria guided evidence-based recommendations, whether it's in Chaun or Ziza or Aboniki. If the evidence supports it, why not? But without it, we're still grasping for straws, Dr. Ide, I'm sorry, or Mr. Ide, at this point, I think we've fully exhausted our time. You've had your hand up, but I think we have to allow closing remarks. We can assure everybody that this is a discussion that ANPA recognizes is well received, and as such, we would look for opportunities to keep this going beyond just today. So please stay tuned and for further announcements. And there's, talked about the psychiatry aspect of it, the nutrition aspect of it, the vaccines. There's so much that we can talk about. But let's just wrap up now. Dr. Bamboye, go ahead and have the last word.
Thank you, Dr. Onyike. We've had a very robust discussion and lecture today. It's been very great. Thank you all. Thank everyone for participating, for logging in and hearing all that have to be said today. It's a moving target, like someone said yesterday, COVID, and it's like we're just going to be learning as we go along. I want to thank Dr. Aham Onyike for excellent moderation as a moderator. Thank you very much for all that you do all the time. I want to thank the ANPA National Executive Leadership for giving us the platform to give this Zoom conference. Dr. Chris Okusiri, who is a current national president, thank you very much. I want to thank all the panelists. Dr. Yemi Johnson, thank you so much for all that you do. We've all heard about first cardiology and all that you've been doing. You and your team are actually very fantastic, doing a whole lot. Thank you for all that you do. We doff our hat to you. Dr. Ngozike Ojioke, thank you for giving us the perspective as to all the anticoagulation and critical care. And Dr. Akinloye Johnson Makanjola, thank you for the lecture and bringing us up to date as to what you do in the ICU. And Dr. Getty Anyawoke, you wear many hats again, like I said, and you are the embodiment of what you do here about this COVID. You are ubiquitous. I have a feeling you have something else going on there in San Francisco, like Aham said, based on the background of your Zoom. So thank you for putting all this together. Members of ANPA, thank you for attending, and ANPA members and COVID-19. And I want to thank everyone at large. We have people joining in from all over the world. And in Nigeria, we have people from Luth, from Lagos, OAUTH, Ife, Zaria, Ogun State, Imo State, Edo State, England, Maiduguri, I think someone from Benue State Intervention, I think that's Dr. Simon. I want to thank everyone for joining from wherever you have joined today. We just want to thank you for coming in. We doff our hats to all of you in the front line of the fight against COVID. This is a nasty infection. The good news that is not affecting our people in Nigeria as much, based on what I heard tonight, is comforting to me, but I hope that is the case. So I salute you all for what you do. I know some of you have had COVID while taking care of COVID patients. That's one of the things that happens. That's why we say we are at risk, we're an at-risk population. So please keep doing all that you do for our people. And you may not get the reward here, but it will surely come. Thank you all very much. If I didn't mention your name, it's not because I didn't want to, but
thank you to Dr. Susan Idionwe and
Dr. Susan Idionwe, thank you very much. Dr. ANPA Secretariat, Latisha. No, Latisha wasn't actually there. That was someone.
Diana, I was here. Thank you, guys.
Okay, yes, thank you so much for helping us. We reach a maximum of more than 100. And Dr. Yemi Johnson, just to let you know, we are not cheap. And
thanks for reminding Yemi.
Yes. so this is a paid conference, a Zoom. So thank you, Dr. Ayaoki. Did I miss anyone?
No, you did so well.
Okay.
Dr. Yemi Johnson, we are so sorry. And our capacity is actually supposed to be higher. For some reason, Zoom did, we don't know. We will find out, but we're really sorry. Thank you for
Can you increase this? Can you increase the capacity next time?
Yes, sir. It's actually increased.
Mike, let me quickly redeem our organization.
We will.
Don't be wrong. We have 500 people that can join Zoom, but like I said, technology have a way of making life hard for everybody when it doesn't work. be rest assured, we have paid for 500 people to get on board.
Very well.
I think 1,000 would be a good. 1,000 would be a good figure, Mr. President.
Thank you all very much, and
please post the YouTube link so that we can refer to that. Thank you.
Let me also acknowledge somebody from Jamaica, Dr. Alex Onyonyo on this call as well, from Jamaica.
Oh, wonderful.
Okay.
From Jamaica.
Yeah.
All right. All right. Thank you all very much. Now, to you in the United States, enjoy the football team. And to you, I know it's about your bedtime. So have a great night. Thank you all so much.
Thank you.
Thank you.
Thank you, Dr. Bamigoye. I am so sorry. I'm so sorry.